he just passed away without any warning last year. I just know him. And if you want to remember one thing about him, it's that he was always defending you everywhere and defending your interests. So I just want to ask you to keep him in your prayers and your thoughts. Okay? All right. Our lecture today will be about the anterior pituitary. Would be about the anterior pituitary. Okay. One thing I guess you have to know about the endocrine pharmacology is that it's extremely linked to the physiology and pathology lectures. So I guess there should be some sort of repetition. But what I try to do is to try to focus on things that will be pharmacologically related. Okay, so I'm not going to repeat too many things, except the parts that I think will be clinically and pharmacologically related. Now, I guess also I wanted to suggest something, which is to ask you if anybody wants to share the stage with me in the next 3 or 4 lectures. I guess there should be some sort of taking things out of perspective, taking an interesting topic related to the topic of the lecture and discussing it for just 5 minutes. So anybody who's interested in coming here in the next few lectures and giving a presentation worth 5 minutes about something related to the topic would be welcome. I'm going to help with that, but I just need it as an initiative from you. في حدا عنده أي interest؟ بدون تحديد الموضوع. Okay, so please stop by my office. Omar already stopped by my office. Anybody else? Okay. So, for example, if we are talking about the anterior pituitary, there are certain things that are undiscovered yet, or things that are problematic. So it's working to just shed some light on these things. So that's the kind of presentation I want from you. There will be no grades, okay? So don't ask me for bonus or anything. I'm just trying to help you try a new thing, get a new approach of thinking and make it a little bit interesting. Okay? ماشي. طيب. To start with the anterior pituitary gland and pharmacology related to that, I decided again to go through the fundamentals. And 4 things I wanted to discuss with you which are related to the clinical pharmacology of the anterior pituitary. So I want you to understand these concepts because they're going to help you a lot when we discuss further the drugs and their utilization in clinical practice. And to start with, I'm going to go through the general organization of the endocrine system, and particularly the HPA, the hypothalamic pituitary axis. As you know, we have the hypothalamus, we have the anterior pituitary, and they are connected together with the portal system, which means that whatever is produced within the hypothalamus could be transported into the anterior pituitary. Does that make sense, or is it wrong?
Yes.
So things synthesized within the hypothalamus could be transported into the anterior pituitary. Is that right?
Mysterious.
No, that's not right.
Mysterious.
Actually, the anterior pituitary synthesizes its own hormones. And the role of the hypothalamus is not to synthesize the hormones produced from the anterior pituitary. It's just to stimulate the production and release. And that's the major distinguishing factor or difference between the anterior and the posterior pituitary. The posterior pituitary hormones are synthesized within the hypothalamus and then transported into the posterior pituitary to be secreted. That's totally different from the anterior pituitary. Did you understand? Okay. Now, the function is to help or to produce the releasing hormone, which goes down to stimulate the production and release of a tropic or stimulating hormone. Okay? When we say tropic, just keep in mind, it refers to nutrition, to something that will lead to build up. Okay? And that's one major function of the releasing hormone. It's not just a release of the hormone, of the anterior pituitary hormone. It's a stimulation for the production of the anterior pituitary hormone. Okay? Such tropic hormone will go down into the target organs to stimulate the release of their target hormones. Okay, and I'm showing here different organs that could be responsible for the production of these target hormones. Why do I care about that pharmacologically? Okay, here's one concept. One of the major diseases of the endocrine system is what? Is less production of a target hormone. Okay? The other, it's the hyperproduction of the increased production of the hormone. Okay. Now, if I ask you a question, through this organization, which one do you think we should use as a replacement therapy if the hormone is less? Target hormone. Okay. That makes sense. But the question is, can we use the releasing or the tropic hormones for replacement therapy? What's normal? Disease where? Okay. That's the point, which is very important. Yes, we can use the tropic hormones and the releasing hormones for replacement therapy, but that's not preferable generally because that needs a downstream or a functioning downstream organ. For example, if I want to give the releasing hormone for the replacement therapy, it means the tropic stimulating hormone, which is the anterior pituitary, should be functioning properly, right? So that's why, in general practice, what we use usually for the replacement therapy is the target hormone, unless there is some sort of a problem that prevents us from using it, and then we go upstream into the target stimulating hormone or the releasing hormone, but that needs functioning or a normally or a properly functioning downstream effector organ. Okay? Keep this in mind for the following discussion. The second concept I needed to mention here is the fact that the target hormone exerts some sort of an effect backwards on the anterior pituitary and on the hypothalamus. And this is what you usually know, and this is what we call the feedback inhibition. Right? This is easy. The other thing that might not have been discussed with you properly is the fact that the hypothalamus and the anterior pituitary could also have an inhibitory effect on the target hormone to stop the production or to reduce the production. And this is something we call the feed-forward inhibition, okay? Which might not make sense, right? Because we said that the hypothalamus is stimulating the release, and then the pituitary is stimulating the tropic hormone to stimulate the release of the target hormone. But on some other pathways, we have the feed-forward inhibition. Do you have any example of this? Let's go back to the somatostatin factor, which is produced from the hypothalamus mainly, and it exerts a feed-forward inhibition on the production of the growth hormone from the anterior pituitary. Now, how can we utilize that clinically? Now, for the feedback inhibition concept, it's used mainly in the clinical practice as part of the diagnostic purposes of the endocrine diseases. What do I mean by that? If I want to see, for example, or to check if the anterior pituitary is functioning well, okay? If there is, no, let's take another example. If I have an excess production of a hormone from the anterior pituitary, okay? And if I want to check whether that production is actually from the anterior pituitary or from somewhere else, what could I do? I could get a target hormone and check whether it will do a negative feedback inhibition on that inhibition does not happen, what does that mean clinically? It means that the production of this, or the excess production of the anterior pituitary hormone was not related to the pituitary itself. It could have been produced from somewhere else. And there is some sort of tumors in your body called, for example, the carcinoma tumors. They mainly have the ability to produce certain hormones. Okay? So measuring the level of the anterior pituitary hormone in the blood does not mean always that there is a problem within the pituitary. Okay? It could be related to somewhere else, for example, a carcinoma tumor producing or secreting a hormone, an anterior pituitary hormone. Now, what should I use the feed-forward inhibition concept in clinical practice? How can I use it? What? Treatment. Treatment of what? Exactly. And this is what we call the suppressive therapy. So, we have the replacement therapy for the hypo conditions, and we use the target hormone. And we have the suppressive therapy where we use the feed-forward inhibition as a general principle in clinical practice to reduce the production of the target hormone or of the tropic stimulating hormone. Okay. The third concept I want to discuss is the pulsatile release. Now, the word pulsatile release, I'm sure, is synonymous in your minds, most of you at least, to the fact that the release of the hormones are related to the wake-sleep cycles, right? Which we call the diurnal variation in the release or the production of the hormones. Okay, which makes sense. Yes, this is the general concept. There is a diurnal variation in the production of the hormones related to the wakefulness and sleep cycles. But that's not the only factor. And you have to keep that in mind when you try to do a diagnostic test or when you try to treat something. There is also the concept of the biological clock of your body, which means what? Some people do not sleep at night, right? And their hormonal levels are also different from a normal person who sleeps during night and wakes up during the day. Okay? So this is an important factor. Another important factor is the emotional status of you. Emotions, stress, whatever, or relaxation and being happy have an enormous effect on the release of certain pituitary and hypothalamic hormones. Okay? The other thing is age. Right? There are certain hormones that are pulsatile or have variability in their production according to the age of the human being or the gender of the human being, as happens with the menstrual cycle effect on the hormonal production, for example, on LH and FSH. And finally, there is this thing. You might have a hormone that produces an increasing effect, increasing grade of an effect, up to a certain point where something else happens that will lead to what? To the clash and the reduction in the production of that hormone. This is something we call what? The counter-regulatory hormones. Okay? This is one major factor playing in the production of this diurnal or circadian rhythm of your hormones. And I'm going to give you an example in a minute how such counter-regulatory hormones can regulate or organize the production of certain tropic or stimulating hormones within the pituitary. Okay. And finally, for that part, why do I care about that clinically or pharmacologically? Because this is something you need to know. Therapeutic regimens sometimes, or and a lot of times, need to simulate the normal pulsatile pattern of release of that hormone. I'm going to give you an example without naming that. Some hormones, for example, produced from the hypothalamus. If I give it continuously, could produce an effect. If I give it in a pulsatile fashion, it could give me a totally different or an opposite kind of effect. Okay? This is why we should care about knowing the exact pulsatile release pattern of that hormone when you want to treat the patient. Okay? And I'm going to take it into an application later on when we discuss the growth hormone. Now, the last of these concepts or commandments is that the hypothalamic and anterior pituitary hormones are all peptides or low molecular weight proteins. Let me give you an example. Here's the growth hormone, which is a peptide having 191 amino acids, 21 kilodaltons or 22, and prolactin also on the same range, or in the same range. But the question is, so what? Who cares? Right? Why do we care about that? This is one concept that we have to keep in mind. But before getting into that point, I want just to show you something which is very important. Such peptide or low molecular weight proteins are considered or are always produced in trace amounts, and they have local effect. And as you know, they cannot actually be produced with, or they cannot go through the bloodstream unless they are bound, because otherwise they would be hydrolyzed. Why is that important in our application of endocrinology? Because it means that these things are very hard to identify initially, and this is why, by the way, endocrinology as a science was not active until the early years of the 20th century. Okay? Can you imagine that? Because we did not have the techniques to discover such trace amounts of a locally effective molecule. The second thing is that they are very hard to purify. Because if I want to take him into a human patient and treat certain diseases, I have to purify that compound to use it. And I have to chemically synthesize that in a commercially available formula to give it to patients. But that's extremely also hard. And that's why the treatment of endocrine diseases, certain endocrine diseases, is extremely hard and extremely expensive. I want you to keep that in your mind when you try to apply such knowledge. Now, the other pharmacological thing is what your colleague mentioned, is that such peptides, when they are released from the oral tabs, will be rapidly hydrolyzed, readily hydrolyzed within the local area. And even if some of that could go through the GI system, they will be poorly absorbed. And that's why it's almost always we cannot use such drugs orally, and we have to go through the injectable formulations. And that carries another kind of risk and problems. Okay? Right. Now, the hormones within the anterior pituitary that you know of so far are the thyroid stimulating hormone. And this hormone will be discussed in, or as part of the thyroid lecture on Wednesday. The second one is the ACTH, okay? And this will be discussed further within the context of the adrenals lectures later on. We have the LH and FSH, and these will be discussed in further details in the urogenital system. By the way, I'm going to teach all of these things. And finally, we are left with two important hormones, the growth hormone and the pharma. And these will be discussed right now. Do you have any question about the concepts before we go on? كل تمام؟ صحيح انتوا Yes, the positive feed forward is the regular thing, which is the releasing hormone. A releasing hormone going down into the anterior pituitary to stimulate the production and the release of the tropic or stimulating hormone. But the feed forward inhibition is the thing we're going to discuss in a minute. Okay, and we will start now with the growth hormone system. But just going through the alphabets of that system. You know that the within your hypothalamus there's a growth hormone releasing hormone. It's going to go down and stimulate the production and release of the growth hormone from the anterior pituitary. The growth hormone itself could be effective, okay, could have direct effects on certain structures, which we're going to mention in a second, but most of the effects related to growth hormone are derived from the somatomedins or the IGF-1 and 2, which are produced from
liver.
From the liver. Okay? That's the general organization. What's the function of the growth hormone? It's widely spread. Okay? But what I want to leave you with is the fact that it's literally a growth hormone. Whatever is related to growth could be stimulated by the growth hormone. To start with, the major function is the cellular proliferation. Wherever it goes, it produces or it leads to the cellular proliferation. But for that to happen, certain biochemical processes have to happen, right? Including the production of proteins, synthesis, and lipolysis, which would be utilized in protein synthesis, and finally, the hepatic glucose output in the form of gluconeogenesis, right? And the other form is reduction in the uptake of glucose by the liver, okay? All of these are environmental conditions favorable for proliferation, okay, for anabolic purposes. You need proteins, you degrade the lipids, and you utilize glucose for the energy production, which would be used in the protein synthesis. Now, how does that translate into functionality within your body? There are two main sites where the growth hormone could have overt effects. And these are the bones and cartilages, where you have an increase in the bone growth and an increase in the cartilage formation. And the other thing is the lean body mass, where the growth hormone could lead to the increase in the lean body mass. Okay. Now, it makes sense saying that it's a growth hormone, that it will have a pulsatile release that's related to what? Related to age, mainly. And this is why you find it at a high level during the childhood. It goes up, up and up, until it starts falling down during the middle to late stages of adulthood. And that's why some people thought that growth hormone could be the anti-aging hormone, right? And there were several studies by certain companies to give the growth hormone for people to prevent their aging or the symptoms and signs of aging and to prolong their lives and so on. And surprise, surprise, the results of these were negative. They were not promising, at least. And the other thing that you have to know is that the growth hormone also has a diurnal variation during the wakefulness sleep cycles, with the levels being very high up during the early stages of the night, where you supposedly go to sleep, okay, and then start falling down during the rest of the night and the rest of the day. Now, why is that important? It's important in the fact that your sleep is important for your growth, okay? Because if you sleep, you will get that high surge of growth hormone, which will be utilized in anabolic purposes in your body. But if you have insomnia, that does not happen, okay? So it's not related to the clock. It's not related. 12 a.m. or 12 midnight, that means I'm going to have a growth hormone surge now. Okay? No, you have to sleep. And you have to have even a full and deep kind of sleep to get the growth hormone surge. So during the medical school, I guess you don't get any. Right? You get stunned at the end.
حاسها بكسر
Why is that? From a teleological point of view, which means what? Trying to understand how nature functions. Okay? خلاص? It makes sense. Sleep is the resting time, and it's the time where you can compensate for whatever damage you produce during the day. Okay? And this is what exactly happens. You degrade proteins during your physical or daily physical activity. You degrade or you produce certain amounts of glucose and so on. So it's time to repair all of these processes during sleep. Okay? Now, one important concept is related also to jet lag. Jet lag could lead also to changes in your biological clock, which also coincides with the decrease or the prevention of such growth hormone cells, and that's why you get so tired, because there is no repair processes for whatever was damaged during the wakefulness period. Okay. Now, growth hormone, again, will go down the regular organization of the endocrine system. There is the negative feedback inhibition exerted by somatogenic, which will lead to reduction in the whole, in the activity of the whole axis. But at the same time, there is also the feed-forward inhibition pathway, which is related to somatostatin production from the hypothalamus. Okay? Generally, from the hypothalamus. Somatostatin will be produced to inhibit the growth hormone production. This is an example of a counter-regulatory mechanism that will lead to pulsatile release of the hormone. You see, growth hormone, releasing hormone, and somatostatins are counter-regulatory. So why do we have an increase in the growth hormone production? Because the growth hormone releasing hormone was much higher than somatostatin. Why do we have such reduction later on during the night? Because the somatostatin's production was increased. This is a counter-regulatory mechanism that leads to a pulsatile pattern of production of certain pituitary hormone. Keep it in mind when you try to use these pharmacology. Now, the diseases, again, endocrine is so simple. It's either deficiency or excess. Now, what do we call the state of growth hormone deficiency? What does it lead to? Dwarfism. Exactly. So it's dwarfism. There is no enough growth hormone that leads to no enough growth. Okay? So they get stunted or a short stature and short bones and everything. Now, on the other hand, the excess growth hormone could lead to two kinds of disease states. These are what? What do you call it? This is gigantism, okay? And the other state is this, which is acromegaly. You know the difference between them? So it's either dwarfism or gigantism and acromegaly. How do you treat? It's easy. Starting with from the top level, which is the growth hormone releasing hormone. Now, according to the general concepts I talked about, where should we use the growth hormone releasing hormone in? Diagnostic. That's the major clinical application of growth hormone releasing hormone. It's for diagnostic purposes. Okay? But could we use it as a replacement? Yes, but there is a condition. Okay? So the growth hormone releasing hormone, which is a very short peptide, okay, is not used clinically currently. It's used only for research purposes, and I'm going to mention why. Because first, it requires a properly functioning pituitary, which makes sense, okay? But that's not what prevents it from being used clinically. The thing that prevents it from being used clinically is that even if you give it by IV route, the half-life is only 4 minutes. Right. When that's the case, what should we do? يعني شغلة أسهل. Try to have an analog of that growth hormone releasing hormone. And this is the first drug we're going to discuss. It's the growth hormone releasing hormone analog, which is called hormonal. By the way, you grow up now. So you have to remember the names of the drugs. Okay? So the question would be, why the drug name? Hormonal. جزء عندنا 4 أو 5 drugs اليوم. Anyways, this hormone is a fragment of the growth hormone releasing hormone, which means what? We took whatever active part of the actual hormone and produced it pharmacologically and commercially to use it as a drug, which is about 29 to 30 amino acids. Okay? Now, what we use it for is for diagnostic purposes. In what conditions? Why do we need to use a growth hormone releasing hormone in a diagnostic purpose? Exactly. So to know if the pituitary is functioning well, you give the growth hormone releasing hormone to see if there is any increase in the level of the growth hormone after that. Okay? This makes sense. But again, that requires a properly functioning pituitary. Okay? If it's not functioning, there will be no production of growth hormone. Now, again, all of the drugs I'm going to discuss today are not given orally. They are peptides, low molecular weight protein, so they have to be used in an injectable way. What we have here is an IV, subcutaneous, and intravenous. And this is the major route of administration for most of the drugs discussed today. But what's important here is that back in 2003, the FDA, particularly the US FDA, approved this drug for use in the growth hormone deficiency. Okay? But it was not extremely helpful or promising, again, because it needs a properly functioning pituitary and you need to control that and test it multiple times to see if there is any kind of response. But why did they use that drug? For that reason, I'm going to mention in a second. But the thing that got out of control was the use in doping. You know what doping is? No. Doping is the use of illegal compounds or drugs as an enhancement in sports. Okay? Because that drug was not very active clinically, people could get their hands on it and they started using it, the athletes particularly, as a doping agent. Which means what? They use it to have an increase in their lean body mass, to have an increase in their cartilage formation, so the repair after the sports injuries and so on. Okay? But again, this is illegal, and the International Committee for Doping Purposes, you know it, اللي بيعملوها بالأولمبياد وكأس العالم وغيره, they test particularly for such drugs. If they are there, you should be banned. Okay? That's the growth hormone releasing hormone. Particularly for diagnostic purposes, some people used it for growth hormone deficiency, but it was not that great or effective. The growth hormone itself, can we use it as a replacement drug? Yes, again, and particularly knowing that the growth hormone, one of the anterior pituitary hormones that have direct effects on organs. It does not need to have the somatomedins to function, right? It could function by itself, but the problem will be what? Exactly. A very short half-life. It does not last for more than 20 minutes. And then the subsequent effects of the growth hormone are derived from the somatomedins production. لما تسمعوا growth hormone, does it remind you of anybody, anyone, anything in life? الشباب والبنات ما توقع شيء. Exactly. So that's the name. Growth hormone is synonymous to this guy. Okay?
كان بيصير وعطوية.
بيلعب بالأزمة.
So, Lionel Messi, a guy who plays football, by the way. But Lionel Messi is a guy who was diagnosed early on, I guess at the age of 10 or 9, as having a growth hormone deficiency, and he was treated with the growth hormone. Okay? And I'm gonna just have a tweak about it in a little bit. What happened? عشان تبقى برشلونة يعني كده. طيب, the growth hormone. Now, one important thing we have to know, again, is that we cannot, because it's a peptide, a low molecular weight protein, purifying that and chemically synthesizing it was so bad. Okay? Now, during the 80s and 70s, do you know how did they get the growth hormone for the treatments? From what? No. By the way, keep in mind, growth hormone taken from the animals was totally ineffective and it could kill the patient. So they used to take it out of cadavers. Until 1984, 86, something like that, when they discovered a disease, I guess you will discuss later on next year, I'm not sure, next time, which is the Creutzfeldt-Jakob disease, okay? Which is a disease within your brain, and that was related to infections from the cadavers that they were taking the growth hormone out of. Like, how did we replace that? Of course, with the DNA recombinant technology. They could use the human form synthesized by the recombinant DNA technology. Okay, and the drug we have mostly, طبعا growth hormone ايش اسمه علميا؟ Somatostatin. The drug we use is
Somatropin.
لا مش somato.
Soma.
Somatropin is the first kind of a recombinant DNA technology produced human growth hormone. Now, again, the major use is in growth hormone deficiency, which is very effective and the golden standard way of treating that. Now, let's go back to Messi. Messi was diagnosed, here's a picture of him when he was 10 years or 11 years, I'm not sure. But anyways, he was playing for a club in Argentina, years old boy, and he was diagnosed with growth hormone deficiency. But, they decided to treat him, but there was a problem. What's the problem? Exactly.
فيش مصاري.
It was expensive. It was costing about $20,000 to $25,000 per year. So they decided, okay, we don't want this guy. And here, Barcelona decided to buy him. Okay? Just for the treatment of the growth hormone deficiency. فيعني هو مش كثير كان حابب شنو بس هم دفعوا له. Okay. What could we use the growth hormone analog for? What other conditions we could use it for?
مش حاسس.
شو في other conditions? The other conditions we could use the growth hormone for, and please remember these things, is a chronic wasting condition, which means what? A patient who has a very chronic kind of disease that leads to cachexia, wasting. So you get the growth hormone as kind of anabolic hormone. Give me one example of this condition. Any cancer, okay, particularly the very aggressive cancer, and the HIV. And HIV, particularly. So this is a very common use in the States for the treatment of a chronic wasting related to HIV. Now, there's another condition. I don't want you to memorize or anything, but just have it in your mind. There are certain conditions where you have a short stature that's unrelated to growth hormone deficiency. Okay? there are certain congenital conditions and certain tumors in your body that could lead to short stature, but unrelated to growth hormone. Now, recently they approved growth hormone to be used for such purposes. Again, it's given injectable form. It's given 3 to 7 times per week, and that's why it was too expensive. They tried to solve this problem. They produced well, they tried to produce that, or to solve this problem by producing a depot preparation, which can be given only 1 or twice per month. But again, it's so expensive. يعني اللي برضه ما يعرفش. Unless you find someone who can fund it. طيب. If we talk about the contraindications, let's talk about contraindications that make sense. Where shouldn't you use growth hormone or growth hormone anadrol? What do you think? Exactly. So an adult with a closed, or a pediatric even, a pediatric patient who has closed epiphysis, you cannot use the growth hormone. There's no problem. What else? Why? Shall we? But there's, yes, if you have someone who is particular, there's a syndrome called the Prader-Willi syndrome, okay? The funny kids. These kids have a short stature, so you might need to use the growth hormone. But they prevent you from using the growth hormone if the patient is already obese, okay? Because that's going to lead to disastrous effects, okay? Now, the first thing is the doping process. This is totally contraindicated. The second thing is the diabetic retinopathy. Why? Growth hormone what? Here. Okay, so by 2 mechanisms. Growth hormone, as we said, could lead to the increase in hepatic glucose output by gluconeogenesis, yes, and by decrease in the liver uptake of glucose. And the second thing is a counter-regulatory hormone to insulin. Okay? So if there's insulin and there's growth hormone will just send it to the trash and take over. And that's why any patient who has retinopathy, which means what? Which means the patient is at an advanced stage of diabetes. So you cannot use the growth hormone at that stage. Pediatrics with closed epiphysis, and finally increased intracranial pressure. And this is just finding out of a study. The children who were given the growth hormone, the major side effects they had were first an increase in intracranial pressure. Do you know why? Or can you guess why? Not really. Actually, it was related to the fact that the growth hormone, one of the major effects was the shifting of the fluids into the extracellular space, okay? And that's why one of the side effects is edema. Do you know the carpal tunnel syndrome?
Yes.
So what they found also as a side effect of growth hormone was an increased risk of carpal tunnel syndrome. Because at these closed spaces, okay, if you have any kind of shift of your fluid balance, that will lead to pressure. In the brain, that led to increased intracranial pressure. In your hands, or these skin sheets, that led to what? To carpal tunnel syndrome. طيب، Somatostatin. احنا خلصنا ولا شنو؟ والله. نايس. طيب خلينا نخلص الجروث هرمون، استحملوا 5 minutes أو 10 minutes. ولا تستحملوش؟ It's up to you. By the way, just one question. الإخوان المسيحيين يوم الأربعاء مين عنده مشكلة بالحضور؟ If we can manage to change that, just let me know. طبعا حقي. فنسقط مع عمر الموضوع. إذا تقدروا تغيروا الأمور خبروا. Okay? طيب, let's move on just with the semester. بعدين مين بده نكمل مين بده؟
كمل خليه يخلص
Just
المحاضرة.
5 minutes.
ساعة.
طيب
طول بالك أهو.
لا ما هو شو نكمل the somatostatin system. Again, as I said, the major function we know about somatostatin is that it's produced from the hypothalamus to inhibit the growth hormone. But that's not it. There are other functions that could be related to somatostatin. First is the inhibition of production of TSH. Remember that for Wednesday's lecture, if we have it. The second thing was that somatostatin was found to be produced within the pancreas. And it produced an effect that I still cannot understand. After all these years, I cannot understand. It inhibits both insulin and glucagon. But I seriously don't know. And I tried to understand, مش يعني مش دي. من زمان I tried to understand why it inhibits both. And finally, which is a very important function of somatostatin, is within the gut. It inhibits the production of DIP. Do you know DIP? Okay, DIP, a very important person. DIP, the vasoactive intestinal peptide, which regulates the blood flow to your intestine, it inhibits that. What's going to happen? Less blood flow. What's going to happen? Less absorption. So just remember that when we discuss the side effect. And finally, it leads to smooth or inhibits smooth muscle contraction, so it leads to delaying of emptying. Okay? But by saying that, give me one disease you produce somatostatin.
Diarrhea.
Is diarrhea related to what? No. Related, عمرك سمعتوا VI pharma. That? Exactly. It's a tumor that produces DIP, too much DIP. So with this kind of tumors, you can use somatostatin. Somatostatin, we cannot use it clinically in its native form because it has a very short half-life again, and because it has too much insulin effects. The effect on the insulin production is too much. So that's why we use a somatostatin analog. And the analog we have is called a drug called octreotide. يعني octreo? Eggs. So octreotide, it means a drug that has just the very active form of the somatostatin structure, which is only 8 amino acids. Okay? Now, octreotide, in comparison with the natural somatostatin, has a much longer half-life. It's not that long, but it's longer than the native product, which is about 90 minutes. It has a higher selectivity for the somatostatin receptor. What kind of receptors we mean here? First off, it's the somatostatin receptors that are present within a tumor, a growth hormone producing tumor. And this is important. The pituitary adenomas or pituitary tumors could have certain receptors, okay? And this octreotide was found to be very highly selective for such receptors. So it's a very effective treatment of a growth hormone producing tumor, okay? But that means also that if it's highly selective for such receptors, the insulin effects would be less. Now it's given subcutaneous, okay, injectable, and deeper preparations. Again, I don't care about these details, but at least know that you are given the injectable part, either IM or subcutaneous or intravenous. Where should we use it? Yes, we should use it in acromegaly. This is the major indication for the use of octreotide. It's acromegaly. Okay, and the other thing is the hormone, as I mentioned. Side effects. Who could give me just a guess?
Constipation.
Constipation is right. Yes, diarrhea is one. What are the symptoms of malabsorption?
Steatorrhea.
Exactly. So sciatica, flatulence, nausea, okay? These are all related to malabsorption. The other thing which is very important, I guess as an example, because somatostatin inhibits VIP and inhibits smooth muscle contraction, it led to less activity and less contraction of the gallbladder itself. Okay? And that's why one of the side effects of Pulsatile is gallbladder stones. Okay? Gallstone. This is related to just less activity of the gallbladder. The last drug we're going to discuss related to this is a drug called Peptide. And the function of this is being an inhibitor or an antagonist at the level of the growth hormone receptor. Okay? So, if we measure the level of the growth hormone, if we give that drug, what's going to happen? I believe. راح تكون increase ولا decrease ولا no effect?
No effect?
Ideally, we are talking about a growth hormone that's already out there. What we're doing with this drug is just to block the effect. And that's by acting on the receptor. Okay? So ideally, the growth hormone levels shall remain increased. Okay? Unless there's what? A negative feedback inhibition that exerted by the IGF-1 and 2 to inhibit the production of the growth hormone. So it's again a later step of inhibiting the growth hormone function, acting on the receptor. And that's why the clinical use of such drug is not that much, because we have the somatostatin system. What we use it for is a resistant acromegaly, which means what? Acromegaly unresponsive to other forms of the treatment, particularly using the octreotide treatment. Okay? It's not responding, so what you try to do is go down to the effector organ and act on the receptor. Yes, it's a competitive antagonist at the level of the receptor. Side effects for pegvisement, they are mostly GI effects, so nobody cares. But what I care about is one thing, is the fact that it leads to liver toxicity. Okay? Such liver toxicity might prevent you from using the drug if the patient already has a compromised liver function. To summarize what we mentioned, in cases of growth hormone deficiency, which is the dwarfism, give me the two drugs I discussed here that will be used. Somatropin and Hormonal, which is the growth hormone releasing hormone analog. In the cases of the growth hormone excess, which is the gigantism and acromegaly, we can use octreotide, which is a somatostatin analog, or Peptide, which is a growth hormone receptor
antagonist.
بالعكس
بالعكس